Thanks so much for joining us today. I'm Courtney Galster here to chat with two leading experts in healthcare innovation, Michael Lunzer, the co-founder and CEO of Utility Health, and Dr. Jerry Osband, the medical director for Impressive Health. Welcome.
Thank you.
Thank you, Courtney.
We're excited to talk a little bit more about AI and automation in prior authorization and just learn more from the two of you, both in terms of your background and your experience in the industry. So let's kick off with just a quick little introduction to who you are and what you do. Michael, do you want to take the reins?
Sure. Thank you, Courtney. My name is Michael Lunzer, and I'm the CEO and co-founder of Utility Health. And from my background, I've been a serial entrepreneur for the last 20 years and have started two companies previous to Utility Health. My last company was in the healthcare space, which we sold to Altegra Health, which ultimately was sold to Change Healthcare. Utility Health was founded within Blue Cross Blue Shield of Minnesota. I was an entrepreneur in residence there and tasked with finding a problem that we could solve and build a company that we could spin out. So that's how Utility Health was born. And for the last 4 years, we've been doing some exciting things in the prior authorization area, and excited to talk a little bit more about AI and healthcare today.
Amazing. Dr. Osband?
Hi, I'm Jerry Osband. By background, I'm a family physician with about 18 to 20 years of clinical experience and about 35 years in healthcare management, focused on software and analytics in regards to care management, programs, policies, procedures, and process. The last 3 years, I've been working with Impressive Health as their senior clinical advisor and medical director to help with their market development and evaluation of client needs and program development.
Well, that's great to know a little bit more about who each of you are, and I think we'll dive into more of your expertise in the space as we go. With AI and automation in healthcare becoming a prevalent topic, we see it almost every day in the news these days. Prior authorization has become a leading space for this type of technology. And I think it's important for us to have an understanding of not only how AI and automation are integrated to prior authorization, but also what the regulatory environment is. So Michael, do you think you could give us a little overview of what you're seeing on a regulatory level in prior authorization right now?
Sure, Courtney. There's a lot of exciting initiatives taking place in prior authorization at a regulatory level. We've seen over the last 3 or 4 years a number of state-based initiatives to try and streamline prior authorizations, namely gold carding regulations, specifically in Texas in the last few years have been one example of things that have been done at the state level. Not all of them have been successful in streamlining and improving doctor and patient experience, but there's definitely a desire to make a change. On the federal level, there was regulatory proposals made in 2020, and then again last year there was a significant regulatory proposal from CMS around prior authorizations. That proposal is still under review. Everybody in the industry seems to expect that it will be finalized here in the next 6 months. And that would require some significant changes in terms of reporting metrics around prior authorizations, as well as infrastructure investments for health plans and payers in the marketplace. And so that's some really exciting things that are taking place. In parallel, you've seen a tremendous amount of pressure put on by the AMA and other provider and patient advocacy groups to streamline prior authorizations because they tend to be a large administrative burden and a factor in the delay of care, which can be pretty significant.
Dr. Osband, how do you think AI, automation, and machine learning are going to fit into some of those regulatory components that Michael was sharing?
Well, I think first we need to focus on what we're talking about in regards to AI, so that we have a foundation for the approach to pre-authorization and recommendations around regulatory compliance. So I think it's important to know that AI, artificial intelligence, is just not a single type of technology, but it's really a focus on the software and hardware to support, as was described, the machine learning, the ability to manage data effectively, and also to include the future of robotics as well. So AI is just not a singular approach to dealing with the dynamics of pre-authorization. So as we think about it as kind of a blend of algorithms, we need to have a good foundational understanding of what the regulatory environment is. So for health plans and other organizations, provider organizations, ACOs, and others, it's really important to have a good foundational understanding of the policies and procedures. And as Michael described it, the exciting changes that are going into the pre-authorization regulatory changes that should help reduce some of the complications and redundancies in the process. So as we look at AI, it's really a way of looking at policies, procedures, and the regulatory environment in order to facilitate the change that will take place over the next few years. So that means that organizations have to evaluate what are their current policies, how do they align to the new regulatory changes or ongoing changes, and make sure there's an alignment there, and then be able to apply AI or machine learning to those policies and procedures once they've been well understood, defined, and you can apply them to algorithmic examples that will reduce redundancy and help reduce duplication as well.
So in prior authorization, we hear a lot about AI. Do you think that AI is the silver bullet to fixing all of the problems that we're seeing in prior authorization?
I think it's really an important aspect of the solution. But when you think about the elements of prior authorizations, and even looking at the CMS proposed regulatory approach, CMS has defined 3 transactions that are part of the prior authorization process. The first 2 transactions really are rule-based data exchange. So for instance, what requires a prior auth? Does my procedure require a prior auth? And the second transaction is sending back to the provider, what are the rules and what data is being looked for? So in neither of those 2 cases do we need AI, but we need really good foundational data and rules from the payer. And then once the provider is either searching their EMR for those records, that's a place where some form of intelligent analytics or database management can help to look through that EHR and find the appropriate data that needs to be submitted. Again, people are calling that AI, but oftentimes it's just rules-based data sourcing to send that data back to the payer. And then the next component of the process is, the payer has to somehow make a decision whether or not that prior auth should be approved. And again, that's an area where AI can help by finding data that proves that the patient has met the requirements of a prior authorization. But even in that scenario, oftentimes it's going to require a human at some point to do a quick scan to make sure that what the machine thinks it found actually is accurate. Over time, we can improve those models and see a high probability of success, which causes people to trust the AI. But until then, I think it's going to require some proof and a visibility to why a prior authorization was approved from an audit trail perspective, rather than just a magic box that's making a decision.
Dr. Osband, what needs to be demonstrated to provide and assure security and compliance in the approach to AI with tools like what Michael's referring to that are being used in prior authorization solutions?
So I think Michael did a really nice job of explaining that the approach is to really automate routine and time-consuming tasks so we can focus as practitioners on the more important activities of care delivery. So within that context, what we want to be able to do is make sure that as we're employing these strategies of data management and algorithmic insights into how to reduce that administrative burden, that those policies are and procedures that align with the regulatory compliance that's in place, as well as accreditation, whether it's URAC or NCQA, state requirements, whether it's Medicaid or the regulatory environment around CMS, that those policies and procedures, both from the health plan side as well as from the practitioner side, are well understood, well developed, outlined effectively, so that the use of the data management and the algorithm align and manage within that context of those regulatory constraints. So in other words, the policies and the procedures have to be well displayed, well understood, well aligned with the regulatory environment. And then you can bring in the artificial intelligence, the machine learning, to maximize the efficiency around that while in compliance with those regulatory issues or regulatory management requirements that need to be fully elucidated and audited and reported on.
And what would some of the challenges be for health plans that want to create their own solution? Could you create an internal solution, or are the barriers to entry just too high?
There are health plans that are attempting to create their own solutions. There's a number of significant challenges, and essentially the economics of creating your own solution are really challenging because the complexity of these solutions is pretty significant. And so it makes much more sense to spread the investment in software across multiple companies rather than having that investment have to be made by one health plan or one healthcare payer. On that note, we are seeing some of the largest health plans creating their own solutions, but then you get into another challenge where health plans are not always the best at developing software. So there's a real big challenge for health plans if they decide to create their own solutions. And we believe that that's not the best approach, but it'll be interesting to see how this market evolves.
Dr. Osband, what do you think providers need to understand about the frequency of rule changes and determinations based on ongoing AI and MLR assessments?
That is a difficult task. The providers themselves at the clinician level, I think, are going to have a really difficult time keeping up with all of the regulatory changes. That's really an administrative task, but it's one that I think has to be designated to professionals in that area. For example, for those of us with Impressive Health, we have a consulting part of our group of consultants that really focus on that whole compliance area, because it does change frequently. There are both local, state, and national regulatory issues that have to be addressed, and compliance issues that have to be managed. And then, as I mentioned earlier, there are also accreditation standards that have to be dealt with. And I think that burden at the level of a provider clinician is extremely hard to stay on top of if you want to practice at the highest level of your art. So I think it really needs to be delegated to professionals, either on a consulting basis, or if you're able to bring that in-house at a health plan or a large healthcare organization, that's where that intelligence, I think, really needs to be housed. So I think organizations such as the one Michael's involved with, and with Utility and others, really need to provide that insight into practitioners, provide them with the security that they can be assured that the consulting or software or hardware organization is in fact compliance with all of those factors through RFP or RFI analysis. So I think it really needs to be outside of the practitioner domain and more in the area of delegated responsibility.
Do you think that there should be a universal solution to, or more of a universal solution for automation in prior authorization?
A universal solution, I think, is not going to happen. There can be universal standards about which organizations can define their programs and policies and procedures. But having a one-size-fits-all universal solution, I think, is not adaptable, at least at this stage of the healthcare market within the United States. You know, unless we get much closer to a single payer type of system, which you know, seems unlikely at this time, I don't think that a universal approach will be adaptable. Michael, what are your thoughts?
Yeah, I think what's really interesting right now with CMS in the Da Vinci group trying to build standards is that I've heard a lot of people call them ambiguous standards, because they've really tried to create a standard method of operating that allows for a lot of flexibility in the way the process is done inside of the envelope or the wrapper of the interoperability. So I agree with you. I don't think there's a near term where we're going to see a single approach. But I think that's one of the benefits of our system and our approach, is that there will be lots of people trying to solve this in different ways. And hopefully the best approach will bubble up to the top.
Do you think that it's wise for providers or payers to break that up into more digestible chunks so that they're not trying to implement a solution across the board immediately and instead maybe implementing in phases? Or do you think they should be looking for the larger solution right now?
That's a great point. We do see a lot of payers that are trying to look at an expansive design. We see other payers that have taken the approach that they know these standards and these solutions are going to evolve. So they've decided to address some of the components that they know are going to be needed. And what's interesting from our perspective is, for instance, in order to implement the Da Vinci standard in any approach, there needs to be a source of truth around prior authorization rules. Some system that knows, number one, whether or not a prior authorization is needed for a particular member, date of service, provider, etc. And then there needs to be another source of truth around medical policies and rules and guidelines. Both of those systems can be implemented today. And what's really exciting is both of them deliver, you know, pretty significant return on investment from the efforts to implement those solutions. Not to mention, you know, for example, the is authorization required system By building an effective system for that, our organization has seen companies reduce overall prior authorization effort and traffic by 30%. So when you think about the magnitude of that against prior authorization, which is the bane of every provider's existence, they hate them, and payers struggle with administrative challenges, there's a solution that can reduce overall work by 30%. That's pretty dramatic, and it's consistent with what's coming for the standard. In other words, there needs to be a system of record that's extremely accurate around whether or not a prior authorization is needed and what those rules are. So that system can be implemented today, regardless of interoperability, and deliver significant value, and at the same time provide a future-proof platform for the payer. That seems like an easy win to me, but I think, again, payers are looking at this and wanting to make sure that those investments make sense and are consistent with the future. But if they peel back the layers of the standards and what's really taken place in this market, they'll see that that's an easy decision, whether they buy that from one of us standalone companies, whether they have that integrated in their system or some other place in their workflow. That's a no-brainer as a way to significantly prepare for what's coming and save money today and make providers happy. There's and not to mention the most important element, which is better care for members, right? Prior authorization has been talked about as getting in the way of care and having a pretty significant negative impact on member satisfaction. So by eliminating 30% of the pain, streamlining prior authorization right out of the gate, there's a big, easy win hanging out there for the payer.
What should they be thinking about, Dr. Jerry, on the front end before they start implementing this new solution?
So I would describe it as a foundational approach. So I think at first you have to really define well what are the current policies, procedures, workflows, performance management strategies that are currently in place. So for example, Impressive Health would evaluate that and give a good understanding of the status quo. Based on that, you would then want to compare it to what are the best practices that are currently in place, with an understanding that organizations like Impressive would have a good, strong background in what is a best practice. So you could apply those workflow procedures against best in practice strategy that aligns with, as we've described, the regulatory and compliance environment and accreditation standards as well. Knowing that, then you could say, what would it take to go from where we are in our current environment, using our current tools, to a best in class or market parity status using the kinds of tools Michael's described, or other approaches that might be strategic for that organization. Doing that, you're able to see what the differential advantage would be. And then you could put a price point around that, as well as a time to value. So you might not do everything in pre-authorization all at once. You might look at certain procedures, you might look at certain policies, certain workflows, so that you had incremental success, knowing that the tool is working effectively, that you're meeting the success goals that you had aligned with the vendor. And then based on that incremental success, add on either other tools or other policies, other procedures, other workflows. So it doesn't have to be an all at once approach. It can be what gives you the best return on value, best ROI, and allows a continuation of your overall organizational strategy to meet the market needs and growth of the organization.
As we're looking at what that future looks like, do the two of you think that the regulations are going to continue to evolve in terms of how prior auth policy is applied?
Oh, I don't think there's any question that there'll be continued change. I mean, technology is advancing, workflow management is changing, the kinds of procedures that are undergoing pre-authorization are different than they were 5-10 years ago. Provider community or practitioner community is developing new ways to deal with technology. So I think there's no question that we're going to see a regulatory and compliance environment that's going to continue to undergo probably rapid change rather than long-term visionary changes.
Michael, with the upcoming CMS regulations not going into effect until January 1st of 2026, as of the date of recording, why should health plans be thinking about implementing a tool today that could potentially help them meet that regulatory environment when they could wait another year to a year and a half to actually gain compliance?
Yeah, this is a very complex area of services, and there's a lot of work to be done. And obviously, we've all seen, fast-paced implementations that have a high level of risk in terms of success. A well-thought-out, planned implementation that can be done over time has a much better chance of being successful at meeting the objective. And again, kind of as we talked about earlier, there are a number of things that need to be done no matter what happens with standards that can significantly enhance the health plan's operation. So for instance, most health plans have their their rules around is an auth required buried in spreadsheets that they publish on their webpage. Utility Health has a product called PA Checkpoint that absorbs those spreadsheets, allows the health plan to more accurately define their rules, and then provides a really easy user interface for providers, the call center of the health plan, or technology to ask our system the question, is an authorization required for this patient, this CPT code on this date of service? Regardless of what happens with standards, that's going to be a really valuable system to the health plan and will improve satisfaction today. So if you wait a year to implement that solution as part of your total implementation of the CMS guidelines, you'll be passing up a pretty significant savings between now and then, and you'll be adding to the workload later on.
Is there any value in beating the rush, so to speak? Maybe like a slow and steady approach. Is that a more effective way to start implementing prior authorization automation, do you think? Or do you think that waiting is something that is still a viable strategy?
You bring up a really important point, and I'm sure Dr. Osband can comment on this from Impressive's perspective, but the market, all of us in the market that provide solutions are expecting a huge surge of activity in the next 2 years. And there's only so many of us out there. So the reality today is that all of us will have more business than will be able to be managed when the surge actually happens. So I think there's definitely an opportunity to get engaged early so that a health plan has a supplier and a partner that's ready to go and can assist them as they're going, because at some point there's not going to be enough resources to help with this. Would you agree, Dr. Osband?
Yes, and I think as we've discussed, Michael, the need to review current workflow management policies and procedures is critical right now. That in order to be able to align with the new technologies, the regulatory changes, you need to know where you're at and be able to have a good understanding of where your strengths are, weaknesses, what types of vendor solutions and capabilities can help bring you to a higher level of performance. So I think that evaluation of current workflow is really critical at this point, as well as an analysis of how are you currently aligning with the current compliance environment, as well as what's going to be expected in the next 6 months. So now's the time to do it.
And do you, Dr. Osband, do you think that there's an easy way for plans to evaluate their current processes, their current workflows, and their current policies? Is there a solution that exists to help them do that? Is that something they should do internally? And how long do you think that average process takes? Is it something you should budget 6 months for, a year for?
Well, I don't think you have time to go 6 months or a year. I think these evaluations can be done in 6 to 8 weeks with a talented team of either internal or outside delegated personnel. The when you say how easy is it, it's difficult because the same people who are going to help give you that understanding of that performance, productivity, and workflow management are the same people doing the job. So you're going to need to pull people off their day-to-day work assignments. They're going to be people who are heavily involved in helping in disease management case, utilization review, pre-authorization. So an organization has to take into consideration how they're also going to allow these individuals to participate in a discovery exercise to improve their programs. So I think number one, you've got to really sit down as an internal the internal leadership, decide how much of an investment you may want to make in terms of taking the time to invest in having those people, those clinicians, administrative personnel be involved in that discovery and back that up with an appropriate time commitment. And it's interesting to think, can you do this internally, or do you really need an outside, so to speak, pair of eyes to be able to look at best practices? And I think it's worthwhile to step back and use organizations that can help apply that best practice standard to give you some insight into what else might be going on in the industry, give you that outside view, and perhaps provide the kind of mentoring and encouragement to staff to say that at the end of all of this, we're going to provide you with the right tools to make your work environment more enjoyable, higher level of satisfaction. You'll be practicing at a level of greater satisfaction. So I think that would be my approach, Courtney.
As payers are looking to review the different policies that they have in place, what are some of the questions internally they should be asking themselves to identify hiccups in the workflow or identify changes that they need to make within those policies?
So I don't think you should start with change first. I think you initiate with what are we doing now? So, there's the idea of looking at everything from how do we get our data, how do we aggregate it, how do we acquire it, how do we apply it to a pre-authorization process, what's our identification of the key points on a workflow management review, what are the areas of most importance to reduce dissatisfaction, both from the health plan as well as the provider standpoint. Get the right people engaged, make sure you've got the right team together to be able to do that, and then establish a reporting strategy so you can lay out all those findings as to what is the current status quo, where are we at, what are the current approaches to dealing with this. Then I think you can start to apply the change strategy against what would be, again, to iterate a best practice, a most effective approach to reducing redundancy, what tools would be most beneficial to reduce the issues that we've identified and help engage more effectively with the upcoming regulatory and compliance factors. So I don't think you should worry about change first. It's more getting an understanding of what your current value proposition is, what your current workflows are, what the current productivity approach is as well. Then you can move to change, getting either internal or external consultants to help you with that, and then figuring out what tools will maximize efficiency and reduce duplication and improve performance.
So it sounds like there's a lot of different departments that are involved in every aspect of prior authorization across a payer. And if Michael, if a organization is identifying solutions for prior authorization in AI or automation, what departments and what people should be involved in those conversations?
Yeah, that's a really good point, a good question at this point, because we find a lot of scenarios where there are different groups within the payer that are looking at this problem with a different lens. And in many cases, they're doing things in parallel, and obviously that's not the most efficient approach. So it's really important to include, IT, the organization, the regulatory or compliance portion of the company, the provider contracting side of the organization, because they know their provider pool better than anyone. And then even down to the call center, because the call center is a significant user of these tools and knows what providers' frustrations are and the call center's frustrations are. So it is a broad group that needs to be brought into the discovery around this challenge. And then you can really make a significant amount of progress towards a solution. But for instance, when IT comes up with a solution by themselves, or the business comes up with a solution by themselves, the business may miss the compliance aspects and some of the technology challenges, and IT may not realize the broad business implications. So it's really important to have a big tent when it comes to looking at these solutions.
So essentially what you're saying is that communication is key, kind of the theme of this entire conversation.
Right.
So and kind of piggybacking on that with communication, how do Utility Health and Impressive Health work together to help payers create the right solution for their prior authorization, AI and automation needs?
So I can address that. We, I think, come together to a payer from a couple of different angles to help walk them down the path of progress, right? So the first step is as we engage together with a payer, Impressive does the current state analysis to understand where is the health plan today, where are the cost elements, and where are some opportunities for improvement. But also, that's not just from a technology perspective, but that's also looking at the medical policies themselves. Oftentimes a health plan has 300 medical policies in place, and they need to look at measuring the impact of compliance in each of those areas, both from a clinical and an administrative burden. And that's a function that Impressive can help with. Once the health plan has decided, what the current state of prior authorizations are and what they want to do for, ongoing initiatives, Utility Health can be a product solution within that suite, and Impressive Health can help implement the utility health platforms. So we really do have a good connectivity between our two organizations throughout that experience for the customer.
Thank you to you both for participating in this conversation. We are going to share all of the contact information for Dr. Osband and Michael Lunzer down below. You can feel free to reach out to either of them or follow their respective companies on LinkedIn. Thank you.
Thank you.